Other side.
A very
Thank you.
good morning to all of you. Thank you, AIOS, for arranging this midterm in a beautiful place like Dehradun and making me part of this. My topic is pearls for the first femto cataract. We know it's a very much promising one. So it has got two parts. One is the femtosecond laser part, another is the manual part. In femtosecond laser part, there is docking, planning of the incisions, setting the parameter for the lasers, capsulotomy, lens fragmentation, putting the incisions, whether it is a main incision or side port, and if needed, we can plan for corneal relaxing incision also. In manual part, it's like a normal phaco, incision opening, OVD injections, capsule removal, hydrodissection, phacoemulsification, and cortical aspirations. So regarding the incisions, we all know incisions are executed accurately with adequate dimension, rapid healing, and there is less chance of SIA. Capsulotomy is very precise here. So nowadays we are planning for this, the premium IOLs, and it's very good to plan the premium IOLs. Nucleus management, the ultrasound energy is emitted very low in the phaco, can reduce the amount of fluid entry in the circulating eye. Excellent for premium IOL. But, there is a but, there are severe intraoperative complications may happen if there is loss of suction during any part of femtosecond treatment, so we may be in trouble. It may hit a pupillary margin, can cause complications. Some capsular problems are there. We have to be very careful for this capsular problem while removing the capsules. So it should be in a capsulorhexis manner, and sometimes you can see there is gas tamponades. They can cause posterior blockade syndrome, rupture of the posterior capsule, and the complications. Now I have a very short two cases. This is my first case, 50 years female with a grade 2 cataract. So everything was fine here. So while doing the incision, I faced some difficulty. So I had to enter with the keratome, then remove the capsule. Proper hydrodissection is very, very important here. So it will help cortic removal. So the nuclear emulsification is very easy as it has been done already. It's divided into parts. The most important part is the cortical wash. So you have to be very patient. So here the rhexis margin is distinct, no capsular tags are there. So it takes a little bit time, and you have to give time for the cortical wash removal, and you can put the lens very effectively. Now this is my second case. Here it's a very soft cataract. The patient choose to do the femto cataract. Now here the hydrodissection was inadequate. The nucleus was so soft that I can't separate the pieces, or can't have a proper chop, or can't aspirate properly. But anyhow, with the very low parameters, just with a patient, I was able to manage the emulsification of the nucleus. Now the part comes, the cortical wash became very, very difficult. The pupil is getting down, and what to do? I have planned femto. I am not eager to put the hooks or the rings. So I thought I should put the IOL, then I will do the cortical wash. What is the rest is there. See, the haptics are attached. So I release it, tried the cortical wash, but it was incomplete. And I hurt the iris, there was bleeding. So at the end, my surgery was in very grief. Now for these types of soft cataracts, I usually prefer to do the flip, and I think this flip and chip techniques are more easier than the femto cataracts. It's very easy to manage. So the thing is, we should select a proper technique in respect to a proper case. So if there is a complicated case like intumescent cataract, subluxated cataract, posterior polar cataract, so we can choose for the femto, but not the easy cases when it makes difficult. We know life is about taking chances, trying new things, having fun, making mistakes, learning from it, but not at cost of patient's vision. Thank you so much.
Thank you, Dr. Deepa, for
Excuse me, what machine are you using?
Yeah?
Which is the machine you're using?
Centurion, sir.
No,
Oh,
Femto.
Catalyst.
Catalyst.
Yes.
What Dr. Noshiri was trying to highlight is, you have now different platforms for doing your femtosecond laser-assisted surgeries. But we have to really look into advancing your technique with your machine only, because you can't have all the machine with you. So whichever machine you have to expertise in those areas also. I think innovations, newer things which are coming in a femtosecond laser, it's been there for more than a decade now with us. I think one thing we desire is portability of a machine to your OR, rather than having a one single OR for a machine. If that happens, things will be easier. Incorporation of a phaco machine within the femtosecond laser device, that will also make things easier for a surgeon. And other innovation which are coming is live OCT, like when you are doing an actual procedure, right from the incision, the capsulotomy, nucleotomy, the OCT should be live so that you know what is happening throughout your procedure also. And third, which is being practiced also now, you have a customized capsulotomy also, where your toric implantation can be easier because it gives you the customization of capsulotomy in such a manner, it gives you orientation for your IOL implantation also. I think these are certain things which will make things simpler. As Dr. Deepa nicely highlighted, there are certain situations where it does have a huge advantage in a performing surgery, like a posterior polar cataract, wide cataracts, hard cataract, subluxated cataract. It can be advantageous for a surgeon. But if you compare the visual outcomes for a point of outcome wise, there would be no difference between a femtosecond assisted surgery or your phacoemulsification which you do in a conventional manner. So that, I think, we know that there is going to be not much a difference. But for patient point of view, it's a huge difference for them, because psychologically they feel they have gone through the advanced surgery, and that we should respect also. Yeah, Dr. Noshiri.
Besides capsulotomy, do you really see any great advantage of femto over the regular cataract surgery? Because capsulotomy also, they say, is not as strong as a manual capsulotomy, because, and this is I don't know what Dr. Titia's view is, but some feel that the capsulotomy is as strong, some say that it's not. So is that a real great advantage also if you're quite confident in doing your capsulotomies? Whereas the nucleotomy is concerned, definitely it makes a difference in the total energy spent. But I would like the panel's opinion about the capsulotomy and how to get a good capsulotomy with a lower energy or with a higher energy. Some people say that the lower energy is better because the edges don't become very friable. But the higher energy only makes the edges friable and susceptible to tearing.
I think, Noshir, you answered your own question. I mean, the problem of the capsulotomy being weaker was more a concern with the earlier set of machines where, there used to be higher energy levels being used, and more importantly, there was a direct applanation of the cornea, because of which there were quite a few aberrant pulses, and there used to be a postage type capsulotomy. Nowadays, because of optimization, because of a contactless interface or a liquid interface, the focusing of the laser pulses onto the capsular excess margin is quite accurate, and the energy levels are also quite less. So there are, depending on who is publishing the study, there are claims that the capsulotomy twice as stronger as, but I personally believe that it doesn't make too much of a difference. And let's look at it practically, whether you're putting endocapsular ring or whether you're implanting an intraocular lens or whether you are, stretching the pupil expansion devices, whether it's a rexis created by manually or by femtosecond, it tolerates all of it. And as a clinician, that's what matters to me. So I believe that, you are getting an accurate capsulotomy and the strength is good enough for all my procedures.
No, actually, this was aimed at people who don't have the machine and still feel that they are not, they are not up to doing a good cataract surgery. So that was aimed at that.